First is, I hope all the presenting authors are present. First paper is secondary acquired lacrimal duct obstruction following rhinoorbital mucormycosis, a case series by Dr. Rinsi Devraj.
A very pleasant afternoon to all. My topic is about secondary acquired lacrimal duct obstruction following rhinoorbital cerebral mucormycosis during COVID pandemic. Introduction. During COVID pandemic, a surge of rhinoorbital mucormycosis cases were seen among immunocompromised patients affected with COVID. Hyperglycemia and systemic steroid administration were consistent risk factors for the development of COVID-19 associated mucormycosis. Secondary causes for lacrimal obstruction can be grouped as infectious, inflammatory, traumatic, mechanical and neoplastic, with numerous etiologies under various these categories. The primary treatment for rhinoorbital mucormycosis involves surgical debulking of all affected tissues, followed by long-term systemic antifungal medications. Methodology. In this case series, I will be describing 3 patients with history of rhinoorbital mucormycosis. All 3 patients were surgically managed for invasive fungal sinusitis with functional endoscopic sinus surgery and presented a few weeks to months later with symptoms of chronic dacryocystitis. First patient was a 41-year-old male with history of moderate to severe COVID. He was diagnosed to have right-sided rhinoorbital mucormycosis. CT orbit with PNS was suggestive of right-sided pansinusitis with bony erosion of maxillary sinus and inferior orbital wall. Patient was managed with FES and right posterior maxillectomy. 6 months after which patient presented with right eye epiphora for 2 months. The first picture is a coronal CT showing right maxillary sinusitis, and CT dacryocystography showing accumulation of contrast within the horizontal canaliculi. Second patient was a 43-year-old male with history of severe COVID, and he was diagnosed with left-sided rhinoorbitocerebral mucormycosis. CT orbit with PNS showed acute invasive fungal sinusitis of left maxillary sinus with extension into periantral region and extracorneal space of left orbit. Patient was managed with FES and left medial maxillectomy. 2 months later, patient presented with left eye epiphora for 1 month with intermittent history of mucopurulent discharge. So first picture is an axial CT showing left ethmoidal sinusitis and CT DCG showing pooling of contrast within the horizontal canaliculi. Third patient was a 41-year-old male with history of moderate COVID, and he was diagnosed to have left sinonasal mucormycosis. CT was showing invasive fungal sinusitis involving left maxillary and left posterior ethmoidal sinus with early features of left orbital cellulitis. Patient was managed with FES, left medial maxillectomy and wide antrostomy. 8 months after COVID, he presented with left eye epiphora for 2 months. CT PNS and orbit is showing left maxillary and left posterior ethmoidal sinusitis. All 3 patients had a common approach. They were subjected to complete ophthalmic evaluation, which included anterior segment evaluation under slit lamp to rule out other secondary causes. Lacrimal syringing was performed and it was suggestive of nasolacrimal duct blockage. CT dacryocystography showed obstruction in the distal nasolacrimal duct with upstream dilation in all 3 patients. All 3 patients were managed with external dacryocystorhinostomy. Post DCR, all patients were asymptomatic and repeat lacrimal syringing was noted to be patent. To conclude, secondary acquired lacrimal duct obstruction is one of the emerging sequels of post-COVID rhinoorbital mucormycosis, which can account to further morbidity in these patients who survived COVID. Invasive fungal sinusitis is likely to cause SALDO by various possible mechanisms, like involvement of bony nasolacrimal duct secondary to erosion within maxillary sinus, and chronic inflammation-related scarring and narrowing of the distal nasolacrimal duct. CT dacryocystography was a useful tool to identify exact site of obstruction in these patients and plan further management. These were my references.
How long was the follow-up?
2 weeks. First follow-up was 1 week after surgery. The next follow-up was after a month.
Any more follow-ups you are planning?
No.
In such cases, you need long-term follow-ups, no?
Yes, the risk of fibrosis and reocclusion is more.
Yes. Recurrences are there.
How was the intraoperatively? Did you find any different findings?
Intraoperatively, more bleeding was noted in all 3
How
patients.
about the nasal mucosa?
Nasal mucosa, actually before planning surgery, we did diagnostic nasal endoscopy in all 3 patients. Since all 3 were post-FIS, nasal mucosa was more inflamed and turbinate and all more hypertrophy.
So which are the first symptoms? Is it the involvement of the sinuses is more first or orbit is the first?
First symptoms.
Symptoms in these cases. The common
All-
symptom in this is,
Epiphora.
so
all
what is
3
the cause for
patients
the epiphora?
That's for 3 possible mechanisms. One is direct invasion of the nasal lacrimal duct by the fungal infection during mucormycosis, or the long-standing inflammation as a response to inflammation, scarring of the lacrimal tissue leading to fibrosis of distal NLD, or it can be iatrogenic. So during FES, any injury to the distal
Now,
nasal.
we have presented 3 cases. In those 3 cases, how does it resulted in epiphora? And
That's
how
what-
you come to know about that this is a mucormycosis?
All 3 had a history of mucormycosis, so they were managed in the same institution. And
They were already managed by.
By ENT people?
yes, sir.
with this
And they
problem,
presented to
lateral
us.
problem, they are presented to us.
Yes, yes.
So then what should be the conservative treatment before going for surgery? Did they
Actually,
receive any such treatment?
no, these patients didn't receive any such treatment. So this is actually an emerging problem. No previous, not much
Maybe
case
true, but
reports.
what is the advised medical treatment at that time
Advised
before you
treatment-
resort to surgery first?
So during the primary inflammation alone, they can be started on topical steroids. That will reduce
about
the
the-
local inflammation.
What about antifungal drugs?
Yes,
Antifungal?
long-term antifungals is needed.
What are that? What is the name of the drug?
Amphotericin, all 3 patients received until a cumulative dose of 2 gram. Later they were switched over to posaconazole.
When you did the lateral surgery, the
No,
antifungal
when we did,
stopped.
they were stopped.
Thank you. Nice presentation.
The second is innovative methods of anesthesia in children for lacrimal surgery. Dr. Ashwini Korane. Dr. Ashwini. The next is comparative study of canalicular injury with and without bicanalicular intubation tube in mechanical trauma. Dr. Riddhi Shah. Dr. Riddhi Shah. CT, computerized tomography, dacryocystography in traumatic secondary acquired lacrimal duct obstruction. Dr. Ayushi Agarwal. Dr. Ayushi. Outcomes and complications in external dacryocystorhinostomy surgery performed by resident. Dr. Shravani Sarkar.
Good morning. Good afternoon, everyone. The topic of my presentation is outcomes and complications in external dacrocystorhinostomy surgery performed by residents. I am Dr. Shravani Sarkar, third year resident in Department of Ophthalmology, Silchar Medical College. No financial disclosure. Introduction. Dacrocystitis is caused by obstruction in the nasolacrimal system with the resulting stagnation of tears. Dacrocystorhinostomy is the gold standard procedure for treating acquired nasolacrimal duct obstruction. A significant number of cases are managed by the residents and the external DCR surgeries are performed by them. In this study, we aim to look at the complications and the outcomes of external DCR surgery performed by the residents. Method, data from all patients more than 18 years of age who had nasolacrimal duct blockage and underwent external DCR surgery performed by the residents were collected prospectively. The procedure involved anastomosis of the anterior lacrimal and nasal mucosal flaps, whereas posterior mucosal flaps were excised. The time period was between April 2022 to March 2023. Results. Data from 136 patients were collected during the study period. The mean age of the study population was 45, plus minus 10.66 years, and ranging from 18 to 65 years of age. There were 112 females, constituting about 82%, whereas males were only 18%. The average operative time was 45.48 minutes, with a standard deviation of 4.72, ranging between 30 to 90 minutes. Coming to outcomes, intraoperative complications were hemorrhage that was present in 14.7%, and laceration of the nasal mucosa that was present in 22%. Due to laceration of the nasal mucosa, about 14.7% was converted to flapless, while with flap anastomosis could be performed in 8.8%. In post-op day 1, there was lid swelling and orbital ecchymosis present in 14% patients. On 1 week follow-up, lid ecchymosis and lid swelling and ecchymosis was also present in 3.6%. There was epistaxis present in 1.4%, whereas hypertrophic scar was seen in 2.2% patients. There was only one patient who had post-op infection. In the post-op period, we looked at the recurrence of symptoms, and also we did the syringing of the nasolacrimal duct to look for patency. In the symptoms, about 89.7% they had no complaints of watering, while 8.8% still complained of persistent watering even after the surgery. Around 1.5% complained of mucopurulent or purulent discharge in the post-op period. Coming to, there were 92% patients who said whose syringing, nasolacrimal duct syringing was patent. It was partially patent in around 5% of the patients, and it was non-patent in 3% patients. Discussion, the success rate was comparable to other studies. The success rate was determined by looking at the symptoms and the nasolacrimal duct patency by syringing. However, the operative time was longer than previous study. In the previous study, it was around 30 minutes, while in our study, it came around 45 minutes. The intraoperative hemorrhage and injury to the nasal mucosa were also higher. And the post-op orbital swelling and ecchymosis were also more frequent. The occurrence of post-op infection, epistaxis, and hypertrophic scar was low and similar to other studies. In conclusion, external dacrocystorhinostomy with anterior flap anastomosis performed by residents has similar success rate compared to other studies. However, the operative time was longer, and the intra-op complications and post-op swelling and ecchymosis were more frequent. The frequency of post-op epistaxis and infection were low, similar to other studies. These are my references. Thank you.
So you are one of the surgeon.
Yes, ma'am.
So what complications you faced during your surgery?
Ma'am, my first surgery, I think I injured the nasal mucosa while doing a bone punching.
Injured the nasal mucosa, completely injured. How much nasal mucosa you require to anastomosis?
Around 1 centimeter square.
That much is also not available, completely taken out.
Ma'am, actually it was injured in such a way that it could not be anastomosed with the
So then what you did in such case?
Ma'am, I had to do it flapless, ma'am.
Flapless surgery. So what complications post-operatively it resulted? How long your follow-up of your case?
Ma'am, we did follow-up next day after 1 week and after 6 months. It was patent, ma'am, but...
Even after 6 months, that flapless surgery was patent?
Yes, ma'am, it was patent.
Did you use any adjuvants? Mitomycin
No, we
adjuvation?
didn't.
So any other complication like hemorrhage and all, how you tackled?
Ma'am, hemorrhage, we try to put like pressure over the area, and then for stopping the blood, Brotoclot eye drops.
So you like the surgery of DCR?
Yes, ma'am.
Ultimately, after doing that, what you felt?
Ma'am, ultimately it did take a lot of time compared to other ophthalmological surgeries, but it was good to see that the patients had improvement in the symptoms.
You want to become oculoplasty surgeon, lacrimal surgeon?
Yes, ma'am, hopefully.
So you should like the surgery. As taking care of the complications. It's an excellent surgery.
Yes, ma'am.
Once you like it, you will definitely enjoy the surgery. But many people are feared about the intraoperative hemorrhage. That's why they avoid the surgery. Okay,
That's
good.
true, ma'am.
Anything, sir?
So you did all these surgeries without any supervision by the faculty, all of you?
So supervision was there, but we handled most
These
of
are the
it.
complications you come across.
Yes, sir.
So what was the minimum time that was taken for surgery? 72 minutes,
So
Yes,
the
they have
average
written-
was 45 minutes. sir.
45 minutes.
But some of the surgeries where there was hemorrhage, there was that took a lot of time to manage the hemorrhage. So that extended to around 90 minutes. That was the upper range. Sir.
So I can finish in 10 minutes. You believe?
Of course, ma'am, I can believe.
You have to believe.
Okay, how you used to make that bony osteum?
Um, so we used a
What sort of instrument you used?
so we used a bone punch.
Bone punch. With the bone punch, if you do, it will take more than 1.5 hours. It is not that easy for a person with a PG. I mean, during residency, even faculty will take more than 1.5 hours to control bleeding and all these things. I mean, these are my experiences I am telling. It's not that easy surgery to be done in 1 to 1.5 hour. It will invariably take more time. And if you can do in a correct plane, it will no doubt you can finish within 1 hour. But usually, because we don't do that often, it will take much time. But you people being junior residents, I think you will take more time. No doubt you will come across some complications, undoubtedly. But, so how many cases you have?
So
made this
136 in 1 year.
136 in over a period of
1 year, sir.
1 year. 136.
Yes, sir.
The most frequent complication is hemorrhage.
Hemorrhage, sir.
Okay. So what was the postoperative follow-up period?
So
6 months or 1 year?
6 months, sir.
6 months. So what were the complications, most common complications, the postoperative period?
So immediately post-op day 1, most of the patients has a lot of edema and ecchymosis.
Okay, that were there, but down the line, maybe at the end of 6 months or so,
So down the line, I think around 8% of the patients said that they had
please
recurrence
talk
of,
to the
they had recurrence of watering in the eye.
what is the reason?
So it could be failed DCR, there could be the lacrimal lump syndrome, a remaining part of the lacrimal lacrimal sac would be remaining there.
It's very difficult. And did you have sutured the posterior flaps or only anterior flaps?
No, so only anterior flaps. We excised
Only
the
anterior.
posterior flaps.
You have excluded suturing the posterior flaps.
Yes, we excised the posterior. We excised the posterior flaps.
Posterior flaps. Okay.
Anybody in the audience want to comment regarding DCR surgery done by postgraduate students? They presented the complications.
Thank you, ma'am.
Was telling me you do it in 15 minutes, that right? Yeah. Right. Do you do the same procedure with only the anterior flaps? Single flap, yeah. So we all are trained. I'm trained from LV Prasad. We only use the anterior flaps. We take out the posterior flap, and the results is almost 99% is the success rate. Similar with you, ma'am? Yours is
99% success.
99% success rate, yeah.
I am very strong advocate of external DCRs compared to endonasal DCRs. All ophthalmologists should learn this surgery or refer to lacrimal surgeons rather than to ENT surgeons. And the success rate is almost 99%. Even today, endonasal DCR success rate is 80 to 85% only, with many repeat surgeries they have to do with endonasal. So for us, single surgery with lifelong results we are seeing. So you should learn very nice surgery, actually you should not be scared of that hemorrhage. You should take care of the hemorrhage in various steps, and you can finish the surgery in 10 minutes or less than that.
Thank you.
So the average of 45 minutes as a postgraduate student is amazing. When I was a postgraduate student, I used to finish in 1.5 hours. But now, of course, I'm trained in oculoplasty, the scenario is different, but it's great.
Thank you, ma'am.
Thank you.
Suction apparatus?
No, ma'am, we don't use it in our center.
Really, suction apparatus helps in doing surgery faster. So without suction, it's difficult to cover.
Ma'am, I have a question. Like with just doing the anterior flap, we have seen one patient which came after around 5-6 months, which had bony growth. Actually, the patient again underwent DCT surgery, means removal of the sac later on. That the growth had been a cartilaginous bone had grown up from the posterior part and just totally covered the ostium, actually bony ostium.
What's the age group of the patient?
It was old patient, ma'am.
Old
That's
patient?
yeah. So we were
Where
very
it
surprised
happens?
because the surgery went very good, because actually I did the surgery before, and later on, around after 5-6 months later, the patient complained. So when I opened it up and I saw that total obstruction had been done from posterior. The flap was still there, it was patent, but beyond that the cartilaginous bone had totally occluded that part, ma'am. So ma'am, what are your...
Osteoblastic activity is seen in
Yeah.
some of the rare cases, recurrence of that entire bone formation. and what
Mitomycin
happens.
C is a good option, no, ma'am, to give, but we gave in that patient also.
What was the size of your bony osteum?
That was quite big, ma'am, around
initially how much?
1.5 to 2
Yes,
centimeters.
1.5 size is
Yeah.
good.
Yeah.
Like we can measure with your tip of your index finger.
Yes, ma'am.
That
So,
much size you should make.
My
that
question
enough.
is that, like, ma'am, have you seen such cases in your, like...
So actually that's a rare case. Usually fibrosis is the common problem, not the bony
Yes, ma'am.
osteum reformation. So fibrosis is the common problem. Bony means you have to do the repeat surgery. That is the only way.
Thank you.
I'll just add one thing here, like when we make an ostium, the bony growth, usually it's the superior part of the bone, you know, anteriorly we go up to the place where the septum is closely adherent to the bone, which is fine, you know. Inferior, you actually expose the nasolacrimal duct, it's that deep. So superiorly, where the, you know, you have the common canaliculi. So there is actually a bone spike which is there. So the superior bone, you have to really go deep and take it out. And that is the place where often, if there is a bony obstruction, it happens. So that superior portion where you punch, you have to actually go well beyond. Not that you go to the cribriform plate, be careful. But still, that is the bone which actually obstructs. And that is right there at the, you know, close to the common canaliculi opening. So if it's not properly taken up, when you put a probe, it's going to obstruct, yeah. So the superior portion, you have to be really careful, yeah. We'll go on to the next, ma'am.
Yes.
Yeah. Thank you, ma'am.
Thank you.
Next paper, H versus U-shaped flap technique of external DCR, evaluation of surgical outcome and surgical time. Dr. Namrata Shri. Dr. Namrata. So we are calling for the second time. Innovative methods of anesthesia in children for lacrimal surgery. Dr. Ashwini. Comparative study of canalicular injury with or without bicanalicular intubation and mechanical trauma. Dr. Riddhisha. Computerized tomography, dactyocystography in traumatic secondary acquired lacrimal duct obstruction. Dr. Aishi. Dr. Rajendra Prasad. Keynote address, AIO's Lacrimal Award.
And we can have more discussion on lacrimal if the time is over. Yeah, after what time the discussion? So we can discuss something about lacrimal only. Anybody can have any doubts and all, you can. Yeah, please come, please. In the audience, anybody having any doubts about the lacrimal system, let us discuss something. So much of time is there. How many of you are doing DCRs? Only 1, 2, 3, 4, 5, 6 here. 7. DCRs.
When do you consider mitomycin in your surgery? Simple, basic question.
I'm Lavanya, oculoplasty fellow from LVP, Hyderabad. Hi. So if there is a failed DCR or young patient, then we prefer mitomycin C, but we can use mitomycin C as a safety precaution so that the DCR doesn't fail in future.
So you use mitomycin C and albuterol as prophylactic?
Like we are using mitomycin C in all cases now.
In
All cases.
That's what Javid thinks?
Yes.
Is there a basic, what's the concept? I mean, has he done any research and lab studies where they have seen proliferation? Javid does a lot of lab studies,
Yes.
I know. So when he has taken a decision, probably there is some concept
Yes.
behind
So
it.
the-
Yeah, you can share it with us.
That cases in which we used mitomycin C, the success rate is like very high. There is no
What is the success rate of DCR in LV Prasad otherwise without MMC?
Since I joined my fellowship, I have seen cases only with MMC and intubation.
Oh, really? So it has changed. So this, I mean, I am 12 years
Yes,
back
you
in
were
LV
there,
Prasad.
yeah.
Yeah. So
Now
that
we are
time
doing
you-
MMC and intubation in all cases.
Ah, okay. That's a nice thing to know. Ma'am, do you want to comment on that?
Actually, I never used mitomycin in my 30,000 DCR cases because what I felt, mitomycin not required actually as a primary this thing. Secondary surgery means failed DCR cases also. We can use a stent rather than mitomycin. I prefer the stent. In one week or 10 days, I remove the stent or maximum 2 weeks. So that helps in preventing the recurrence and all the things. But mitomycin, no, I don't think it is required if you do meticulous surgery.
So in my practice, my indication for mitomycin is limited to secondary surgeries, failed DCR surgeries. If there has been a severe acute dacryocystitis in a patient and then the patient is coming for a DCR surgery, and if at all there is some canalicular obstruction that we know, intubation is more important as ma'am said than MMC. So
Where
these
we are
are the
doing trephination.
right. So and it's around 99% success rate without. Yeah. Thank you for telling us.
Thank you.
As ma'am said, 3 to 6 weeks. Yeah, sometimes 3 weeks or 3 months also we keep. Yeah.
CDCR tubes, we keep it for 3 to 4 months.
Yeah.
When there is canalicular obstruction, we pass the tubes through bicanalicular stents. We keep them for 3 to 4 months. But failed TCR cases, when you are using a stent, naturally we can remove after 2 or 2 weeks maximum.
I keep it for 3 months in my practice. Yeah. Any other questions since we have time? All right. We have 15 more minutes.
This keynote address, Dr. Rajendra is here.
Not responding. I am making call for Dr. Rajendra Mukher. He is not responding.
Actually, there is a print mistake here in the paper circulated to us. The keynote address is by Dr. Raviranjan, Lacrimal Award, first midterm conference at Patna. Bumpy roads to failed DCR made smooth. So Dr. Raviranjan is supposed to give that award presentation here, but mistakenly they printed a cataract surgery here. So which is no way related to our lacrimal stent. Dr. Raviranjan not there. Any other discussion you want to make regarding lacrimal?
How do you handle CLLU, congenital congenital nasolacrimal duct obstruction? What are the current perspective, current developments?
See, that's very interesting question. Sir, doctor, your name?
T. Venkateshwar Rao. I'm located in Vizag and currently I'm in Saudi Arabia, Riyadh. And just now, my number is, my registration number, IAOS R6934.
Thank you very much for the nice, very interesting and important question he asked. How do you go about the congenital nasolacrimal duct obstruction, the latest way we manage? I do like this. When the patient is brought from 0 to 6 months, I advise them massage and antibiotic drops. After 6 months, probing I advise them. Nasolacrimal duct probing under short GA. Some people do without GA also, but which is not advisable. That is from 6 months to 1.5 to 2 years. The success rate of the probing first time is almost 90%. If you have to repeat also, the success rate goes up to 95 to 99%. Very rarely second probing fails. Unless there is some bony obstruction already formed there, the probing fails. Then after 2 years, still I advise them for a probing prognosis. Success rate will be very much less. Then from 3 years onwards, DCR under general anesthesia is the advice. My youngest patient was 2.5 years age. Successful DCR under general anesthesia was done for him. So the criterion for taking the cases like this is, in India we see a lot of cases with mucopurulent discharge, not simple watering, which is very much indicated for probing or DCRs at the early stage. We cannot leave them like that. They can go into acute dacrocystitis, lacrimal abscess, and spread to the cavernous sinus, sometimes intracranial manifestations also. So we cannot wait in such babies with the infection at the lacrimal sac area. So we need to take up them as early as possible for all these things. So, any, pardon?
Any surgical intervention may change the patient's anatomical changes?
Nothing. The eye is more important than the cosmetics.
Yes.
Cost of each eye is in crores, and cosmetics you can, we are cosmetic surgeons, we can,
Not a generalization. Facial development up to 12 years age. Facial growth of the bones and all. Before that, do you educate the surgical procedure in the change?
nothing will happen, sir, because we have amount of bone nothing happens, but not every case. Usually, as Fairuz said, normal age group is 4.5 to 5 years.
Madam, during messaging, only antibiotic drops are to be installed.
Yes, sir. Antibiotics also should be installed before 6 months of age.
Is there any option of using soft NSAID or soft steroid along with antibiotic? Any
Drops?
recommendation? Soft steroid or soft
No.
NSAID?
Steroids we avoid, sir.
NSAID.
We avoid steroid, only plain antibiotics along with the massage. What do you before 6 months?
Steroids we don't use. So usually
It is a
for
big no.
older children,
It is a big no. It is a big no.
post-operatively, after probing, I usually use steroid for a short period of time, sir. But I want to know.
During messaging, no steroid.
No, sir. No steroids during massage. Plain old antibiotic.
Regarding NLDO, and we use the term Kridler's massage. So there are occasions where parents generally massage. They just massage. So I think the name has to be changed to sac compression.
Yes.
You know, like when you tell a parent to massage, they're giving nice coconut oil bath and giving a massage over here. No, I'm not joking here. So in fact, I think we should change that name to sac compression. It's like, it's basically compression of the sac rather than massaging the sac downwards.
Yes.
It's like really going in compression, the medial canthal tendon, just below that is the sac. And this is how you actually have to tell the parents to do the massage, because massage itself has a good outcome. So if they do it properly, most of this actually gets resolved. So I think we should all change the terminology of massage to sac
Yes,
compression.
I 100% agree with Fairuz, because massage means what they are doing is like this, like this, like that. That is very bad. Actually, we are spreading the.
Ma'am,
He should tell them how to do. First, to press the sac and come downwards, creating a negative space there, so that that opens itself. Massage means they just do like that, like that. That is not. Doctors should explain, not the nurse or attendant. We are responsible for the babies. We should explain.
ma'am,
Even please don't leave the syringing part to the your whatever assistants in the OPD. They don't know where is the punctum. They don't know what is the direction of the canalicus. What is the direction? Any postgraduate student, please tell me. The canalicus, how is it directed? Lower canalicus, please. Volunteer. No postgraduate here, or they don't want to volunteer.
ma'am, what?
Usually it goes down and then medially, no? So how many of these optometrists or ophthalmic assistants who are trained very poorly? They are knowing about this direction. They are spoiling that canalicus by their syringing methods. Syringing is such a delicate procedure. Doctors, please do yourselves. Don't leave that procedure. Everything else you do, but syringing, ye karke leke aa jao. That is not the thing. That there we are seeing all the problems. Spoiled canalicus. Okay, you are.
Ma'am, what about the choice of antibiotics actually?
Huh?
Choice of antibiotic, which topical?
Children below 6 months,
Yes, ma'am.
tobramycin I usually
Only that?
my choice. Sometimes we require to use quinolines also, but usually I start with tobramycin. What do you say?
Actually, from what I have seen, pediatricians, they actually prescribe, I don't know how they got this in, Vigamox. The highest antibiotic we use in ophthalmology, they usually prescribe for a 3-month-old baby, but that should be.
Vigamox is better than gentamicin. I am seeing some non-ophthalmic physicians like pediatricians, they are prescribing gentamicin drops in small children. Have you heard of gentamicin drops? That is very epithelial toxic to the cornea. That's what I am telling.
There is no option in the pediatric. Or otherwise with looking drops, or if there is any true bacteria, you will use a tobramycin or there is no.
What about levofloxacin?
Yeah, any fluoxetine you can use,
Yeah.
but to start with the tobramycin, if it is not responding, then you can at least go for it. Any of the.
And somebody says should not be used for more than 2 weeks. Is it correct? Tobramycin.
Ma'am, first, if we use.
It has some neurological side effects, neuro effects in cerebral complications. That's the reason including the smallpox is a little less used in newborn. But we have only one option like tobramycin or gentamicin. Otherwise, just erythromycin.
Not available.
Ma'am, like if the patient comes, first episode we can try tobramycin. If after 1 or 2 weeks the patient does not respond to the lacrimal massaging, the watering does not reduce.
Age group?
Small, like 1 or 2 months.
1 or 2 months.
So can we give short duration, like for 1 week or 2 weeks, try with moxifloxacin or other antibiotics actually? Because sometimes they do not
Ideally, you should
respond.
do the culture sensitivity test.
Ma'am?
Culture.
Culture sensitivity.
So ideally you should do, then proceed with the other antibiotics.
Okay.
So we cannot play with the antibiotics, especially in children. Because this is not responding, put that is not responding, that is not our whatever choices. First one, at least one you can directly put, but if it is not responding, stop that for 2-3 days and
Culture.
do the culture and then go ahead with the whatever.
Yes, ma'am, it's a better approach.
One more point that I would like to make here regarding the sac compression. Of course, it is a treatment modality to, get away the valve to open up. More than that, it also helps in preventing the collection when you're directly going. It's like Roplus, right?
Roplus.
The mother doing Roplus 4 times a day. So
How many
that
of you
also
know what is
reduces-
Roplus? Anybody from PG students? I want the PGs to come up and answer the questions. Anybody? What is Roplus? Very good, very good. You are a student or a fellow? PG. Very good, very good. So that is the only test required when the patient comes to you, the OPD, adult patient or small children, anybody, just to put your index finger over the lacrimal area, sac area, and press there. If you see the pus coming out from the either lower punctum or upper punctum, you need not do the syringing also. That means your distal pathway is okay. Your obstruction is at the level of NLD. So directly you can proceed with the surgery. And if it is negative, Rho plus negative, then confirm the canicular obstruction or any other thing by doing surgery.
Yeah, so going to your question, if they give a good compression, so there is no, basically when does infection happen logically? When there is collection in the sac. So when you're frequently doing a sac compression, which is like, massage, not massage, it gets cleared up. So the chance of infection in these babies also is less because you're clearing up the sac as soon as it gets collected until you want to do the probing at 6 months or 9 months. Yeah.
Yeah, very right. It will help also, therapeutic also.
Ma'am, we'll go with the next session,
Yes.
3:15, yeah.
Thank you, all my co-chairmen and conveners and everybody. Thank you, sir.